Can everybody see that okay?
Yes, we sure can.
Okay. So again, we're just going to quickly talk about criteria, go through some medicines, and really talk about side effect management and establishing efficacy today. Just a really key reminder is the diagnosis of ADHD includes symptoms present before age 12, verified in 2 settings or more. And again, that is why that collateral is so important from everyone that works with kids. And it has to cause some degree of impairment. If it's not causing impairment or dysfunction, we usually don't treat it. And in terms of like thinking about what medicine actually does, because medicine does not do everything, but medicine targets key symptom areas that often have biological underpinning. So it's those 3 core symptoms: attention and focus, impulsive behavior, and hyperactive behavior that is going to be the sole focus of what these medicines can accomplish. They don't help oppositional behavior. They don't help talking back. While those things might get better if ADHD is driving other problems, the medicine is really addressing these core foundational areas. And there are 4 types. The most common type is combined, where people have all types of symptoms: hyperactivity, impulse control, and attention problems. There's a large chunk of people that only have attention problems, or the inattentive type. And that may be a little harder for people to observe. So if you're doing close one-to-one work with kids, that may be where it becomes most obvious. But anyone want to guess what one of the most sensitive activities that we do day to day that actually requires attention that most people report as something they can't do? It's very subtle. What's the hardest thing to do if you're having trouble paying attention and it's just attention? Anybody have a guess?
Listening?
Well, listening is actually a really big part of that. That's actually really important. That's not the one I was thinking of, but listening is really important because you miss things and it can be subtle and people might not know. So I'll add that to the list. Yeah. What's the flip side of listening?
Reading.
So reading is incredibly important. And so one of the things that I frequently focus a lot at assessing attention symptoms is, how do people do reading? And I'll ask kids how their reading is going. I often want to know how long it's taking them to read books. People that are really struggling with attention and focus often report having to reread things over and over again, lose or get distracted in the middle of a passage, have trouble remembering all the aspects of the passage. And so reading can be incredibly important. In fact, a lot of kids will end up not liking reading because they can't hold it together long enough to understand the story. And this becomes really important around 4th grade, when even math and science often switches to reading-based materials. So as kids get older and the hyperactivity and impulsive symptoms are less obvious or better treated, those inattentive symptoms may be still very present and much harder to see. And so I spend a lot of time thinking about reading and listening too. You can certainly ask parents about, do they seem to miss instructions, or even multi-step instructions. If I ask someone to do 5 things, did they only hear the first thing I said, can also be sort of a sign of inattention. And generally speaking, it's much harder. Assessing medicine, even on those teacher reports, unless they really are doing one-to-one work with a kid, may still miss some inattention symptoms. Whereas if you have a kid running around the room and climbing the bookcase, everybody notices that. So when we're talking about medicines, we want to make sure we're addressing all of them. Here are the symptoms of inattention again. Here are the hyperactive symptoms. And then these are the impulsive symptoms. And one of the keys in kind of working with people too is looking for them in conversation. And sometimes you have to listen too and just pay attention. Did that kid interrupt me? Did they miss something? Did they talk really fast? Did they blurt things out? Sometimes when you're feeling annoyed, if they're interrupting you or blurting things out, you forget that that's a sign of ADHD because behavior is disruptive. Or if they're not paying attention, you might think they're ignoring you on purpose or wanting to play video games, which may all be true, but you have to kind of learn to look for the subtle signs of ADHD as well. So why do we consider treating ADHD? It's one of the more common childhood conditions, but the reason we think about treating it is because it's really impairing people. If kids don't have problems from those symptoms, why would we ever want to do anything about it? But untreated ADHD has a lot of consequences for kids and their development. And these are just a few. Because of some of the hyperactive, impulsive behavior, maybe risk-taking behavior that comes from lack of self-control, we do see higher rates of accidents and ER visits in kids. It's especially problematic when they learn to drive. Even adults with untreated ADHD have much higher rates of and this is even before the cell phone distraction phenomenon. If you are distracted, you have higher rates of being in an accident. And that has kind of borne out, especially in kids whose medicines wear off. And as people get older, they may not have as much symptoms of hyperactivity or impulse control, but attention may take much longer to treat. And so if you have a kid that's driving, you really want to make sure that they're paying attention or they're medicated while they're driving, because they may have trouble learning that motor memory that goes with such an important task. Untreated ADHD has clearly been linked to substance use. This is a huge problem, and there's lots of theories for that. One is sort of the self-medication theory, that if they're suffering that much with impulse control and focus, they may turn to other things like nicotine or stimulants or things to help them sleep. And we know that untreated ADHD clearly has higher risks of substance use. In fact, treating ADHD before puberty, regardless of what medication you use, even stimulants, actually decreases substance abuse risk repetitively in studies. And again, the criminal behavior is probably largely linked to the substance use that comes with a lot of our criminal justice system, is the impact that substances have on that. Kids struggle to listen, and that means they might struggle at home and school. And they might struggle with their friends. I tell people paying attention and focusing isn't just for schoolwork. And a lot of my kids who only want to take medicine at school or only during school struggle with untreated ADHD if they aren't listening to their parents or aren't listening to their friends. It's hard to talk to somebody that if you think they're ignoring what you say or they interrupt and blurt things out. It can really impair people's social abilities. And so it's important to realize that ADHD is going to exist in all settings, and the difficulties might not be at school. In fact, a lot of really intelligent kids who do just fine at school, especially first, second, third grade, may have far more troubles making friends or taking turns on the playground or playing sports than they actually do in school, because they have the cognitive ability to do well in school. They quickly memorize and get information, but it's the social challenges that might be more problematic for their symptoms. So it's important we realize that too. If you're struggling with organization and paying attention, there's risk that you won't perform in school as well because of the executive functioning deficits. And not performing at school or feeling like you're not successful or can't control yourself or you're always getting in trouble can really lead to lots of other mood pathology and anxiety and self-esteem issues down the road. In fact, one of the most helpful things most kids tell me when their ADHD is treated is they just feel better. They feel more in control. They don't have to put as much energy into focusing and concentrating, so they can put it into learning or relationships or other areas, and they feel less exhausted. Most kids, when they're well treated, believe it or not, will beg to stay on their medicine. Even if their parents want to stop, some of them will just tell me they feel better not dealing with that. And I didn't put this on here, but if you think about the biological underpinnings that we're going to talk about next, if you have trouble kind of controlling your impulses, you also have trouble controlling your emotions. And we see a lot of issues with mood dysregulation and irritability and problems just if you have a big feeling, kind of controlling that feeling. And some kids can feel kind of very out of control with their emotions as well if they're impulsive in their emotional regulation. So these are the reasons we think about treating. So the biology of ADHD is kind of nerdy, and I get a little nerdy about biology, but I think it also helps to understand how some of these medicines work. The large majority of medications are affecting our noradrenergic and our dopamine system. They may have direct effects on the gray matter in the brain. Specifically, the frontal lobe is the area that most executive functioning localizes in sort of brain functioning. But there's some other constructs that might also contribute to ADHD symptoms. Anything that infects blood flow or hypoperfusion to the frontal lobe might manifest with something. Now, I gave a lecture several months ago where we talked about the impact of in utero substance use, where you have direct toxic effects on the frontal lobe, where you actually kind of have like brain damage and lose frontal lobe effects that can be the result of toxins. But there's also some very genetic level sort of phenomenon, especially in biologically inherited ADHD that runs in families, where you see abnormalities at the receptor and the transporter levels of how the brain handles these hormones that might impact how they work. The other thing I want to put out there, and this is my favorite slide ever, this is my resource list for ADHD medications and ADHD in general, because lots of parents have lots of questions and get very worried or concerned about ADHD. There's a lot of bad information out there. So especially the one here in the middle, the ADHD medication guide that's available online is really excellent. And the American Academy of Child Analysis and Psychiatry has a resource center where they really talk about many of these concepts, help parents understand how to choose medicine, monitor side effects, and really play an active role in that. And really talks about this at kind of a level that I think can really help parents make a good decision. Some are begging for medicine, they're struggling so much, but I think most parents, to be honest, are very reluctant to consider medicine. There's a lot of guilt parents have about sometimes feeling that they have to give their kids a medicine. This is a highly biological illness, and it's probably the one we know the most about medicines about. And so I really urge people to kind of weigh that balance. There's a lot of struggle with medicating ADHD that doesn't seem to exist in other conditions. And I like parents to have all their information, but also realize that their feedback and what they observe and what they notice is going to be a key part to getting these medicines right. So really making them part of that team to make sure that we're getting things covered consistently. The other part, although again, I am heavily focusing on medicines today, medicine does not treat 100% of these symptoms. And so it's really important to think about other treatments that exist, talking about what ADHD is, what it isn't, talking about other school interventions, 504 plans, social skills, behavior treatment, if that's a bigger part of it, can all be helpful. Teaching a parent how to get a kid's attention can be just as important as helping the kid pay attention more. And so the medicine does not exist in a vacuum. And again, the medicine is just targeting those three things: attention, focus, and impulse control. It doesn't help teach the kids the skills once they learn how to do those things. And for people that have been suffering from ADHD for a long time, the fact that they now pay attention does not mean they automatically know how to have a good social conversation or interrupt appropriately. You have to go back and teach that once they have the basic foundation. When we talk about sort of the neurotransmitter theories in psychiatry, we're really talking about dopamine and norepinephrine. Both of these have a big impact on focus, concentration, executive functioning. I just like this slide talking about how different aspects may play a role in this concept of distractibility. So these are the FDA approved medications that we're going to talk about. These all have FDA indications, not just for ADHD, but pediatric ADHD. In fact, all the medicines have pediatric ADHD indications, but not all have adult indications, which is kind of interesting. While all the medicines often work in adults, some of those branded medications have gone after specific approvals for adults, but all of them carry the child specific. And most of them are age 6 and up. Short-acting amphetamine did have an FDA approval down to age 3 at one point in time, but remember from my previous lecture, FDA approvals do not always mean everything in terms of evidence base. short-acting methylphenidate was actually the preferred agent in some of the preschool ADHD trials. So again, these are 6 and up officially. So stimulants go by a lot of different names, and I have a really cool chart I'm going to share with you later and talk a little bit more about. But what I really wanted to make you aware of stimulants, because you can be inundated with the number of names and you'll see fancy schmancy names all over this list. But stimulants really only have 2 forms. You have your methylphenidate products that you see on the left, and you have amphetamine products that you see on the right. And they work the same way. The reason all these medicines are different is because how they're packaged in the pill by the pharmaceutical companies. And they have different release patterns, they have different length of time that they work, and may come in different forms. Like, can you chew it? Is it a liquid? Does it dissolve? But they fundamentally are only 2 types of stimulants. And they're very similar. Even though I'm going to talk about some slight differences, the reality is they all possess the same potential for side effects that need monitored throughout. So despite the 30-some names that exist, there's really only 2 kinds. What makes me, I guess, an expert at ADHD is I actually know how each one of them work and is released and the timing. I'm going to share a little bit of that with you today, because once you learn that, the secret of my success is long gone. So, but they really all do kind of work the same way. So the way they work is in our frontal cortex, and I want you to note that I did highlight frontal, so that's that area behind your forehead. Okay. The stimulants work at directly increasing dopamine and norepinephrine at those centers. They work slightly differently, but they both have that same effect. And so if you look here at the receptor terminal, the Adderall actually helps it release directly, whereas the methylphenidate has a little bit more of an upstream regulation that, while it ends up looking like this in the synapse, actually takes a little bit longer to increase it. And this is important in 2 ways. The Adderall tends to be a little bit more irritating because it releases fast, and so it has a little bit higher rates of irritability in studies. And Adderall has a much higher street value on the black market of dealing because it has a higher addiction potential because of that fast release, okay? That does not mean that methylphenidate cannot be abused, but it just takes longer for it to kick in slightly enough because it's a longer release pattern than the Adderall. So although head-to-head, these medications work very similarly and consistently, those 2 slight differences may explain the difference between the 2. From a patient perspective, patients can respond to all of the stimulants. They can respond just to methylphenidate. They can respond just to Adderall. They could respond to none of them. It's very hard on a patient level to predict who might respond to what. But if you have a patient that particularly seems more sensitive to the amphetamine product class, and it's not a release specific issue, sometimes we switch to the other class. So if they really got agitated with amphetamines, I'll likely switch and try the methylphenidate products instead. So as I said, they're all used for ADHD. They do have some off-label uses. One is the hyperkinesis of developmental delay, which is the idea that this is severe hyperactivity, largely related usually to intellectual disability or autism. It's been used in low doses in traumatic brain injury to help with cognitive recovery. We can also use stimulants, have some antidepressant effects, and so they're sometimes used in severe depression. But their FDA indication is all for ADHD. So of all the things I do, this is by far the most evidence-based. As I said, there's a lot of things I do with a lot less data. There's over 200 studies. We know so much about stimulants. We know what they're capable of. We know what they're not capable of. We know their side effects. Parents are always worried about their kids being guinea pigs or testing things out on kids. This is not the case for stimulants. We know more about these medicines and how they work than just about anything. This is even better numbers than what you see in pediatric antibiotic trials. So these are well-researched medications. The general rule of thumb is about 70% of people will respond to the first stimulant you pick. If they fail that one, I usually switch classes or I switch the way it's released. Usually 90% will respond. And then by the time you do the third stimulant trial, about 97% of people should have a response. Again, if they're not responding after 3, I go back to the drawing board and really make sure I have my diagnosis right. And again, you see some differences here. Focalin is essentially a methylphenidate product, but it's the active isomer of the methylphenidate. So it's called dexmethylphenidate. And then dextroamphetamine and amphetamine are just different beads in the mixed salts that come with Adderall. And then lesdexamphetamine is Vyvanse, which is a prodrug that actually has to be cleaved in the liver to work. So you get a little different release pattern with that one. But again, they all either are methylphenidate or amphetamine based. And the key part with these medicines is literally timing is everything. And I have to really teach people about that. This is true of every Schedule II medicine. If the medicine is not in your system, it does not work. So if you only take the medicine at school, it only works at school. And as a parent, it's gone by the time they come home and you've never given it on the weekends, you're gonna tell me you don't see it working because it's not in your kid's system when you see your child. And so it's really important people understand that. It's really important to me that I talk to people and I say, look, timing is everything with these medicines. I need to know when you take it, when you think it starts kicking in, how long it lasts, and when you think it wears off. Because everything I do to adjust it is based on those symptoms and side effects that you report related to timing. And so understanding the timing really matters. The immediate release medicines are about 4 to 6 hours, and the long acting can get up to 8 to 12. Obviously with school-age children, so age 6 and up, we prefer a single dose of long acting to try to give as much consistent coverage throughout the day. But that being said, some kids, especially high schoolers with significant homework demands, may need a little extra booster dose after school. And some kids metabolize things very quickly. The younger you are, the faster you metabolize things. And these rules don't always apply. There's a lot of I always get them wrong, I think it's pharmacokinetic differences in the metabolism of some young kids. And some parents end up reporting that they don't seem to last as long as you think they should. And sometimes the teachers verify that when you give reports as well. I've had some little ones report only getting about 2 to 3 hours out of IR, and some of the long actings only getting about 6 to 8 hours, and that's borne out. So you really have to get the data from your observers to figure that part out. So the dosing is not as complicated as it looks. Why dosing matters is because every year the insurance panel negotiates their rates, and what was the preferred medication in one year might change the next year. So sometimes you're having to switch between products because of cost. But at the end of the day, it's not as difficult as you think it is. And there's lots of conversion calculators available online where you can type in the dose of one and it converts it to the other for you. But a simple rule of thumb is that 10 milligrams of methylphenidate equals 5 milligrams of amphetamine. So you have a patient on like a Metadate CD product, which is a methylphenidate. They're on 40 milligrams of Metadate CD, and the insurance suddenly says you have to do Adderall XR. It's 20 milligrams, half the dose. And you can convert them both that way. However, there's a couple of exceptions to that, and that's for the drugs with really different release patterns. Focalin, because it's just that active isomer, and dexmethylphenidate is actually equivalent to amphetamine. So Focalin XR10 actually equals amphetamine XR10, which would equal methylphenidate 20. And then Vyvanse is one of the most popular agents out there, which we'll talk about a little bit. But it's a prodrug, so you have to take it. It has to go through first pass metabolism in the liver, has a completely different dosing system. Use the calculator for that. The other trick with the long actings is how they're packaged. Many of them have different coatings on the pills, or they're in a bead system, where some of the beads are immediate release and some of the beads are long acting, and they may have different ways that they're released, and this may affect the timing. There's a new agent on the market called Modius that is actually triphasic, where it essentially has an immediate release, one that kind of gets you to the end of the day, and then it has a second one at the very end, or a third one at the very end that's supposed to like be an extra IR coverage for the evening. So it's trying to replace essentially maybe 3 doses of medicine instead of 2. So this is the release pattern of some of the most common medications that you see on the market. So Ritalin LA, Focalin XR, Adderall XR are beaded modalities. And when something's in a capsule, in a bead, you can actually open the capsule up and you'll see the beads are different colors. In those products, half of the beads have an immediate release and half of the beads have a longer acting release that gets the afternoon. So if you have something like Focalin XR 10 milligrams, that's actually equivalent to giving Focalin 5 milligrams short acting twice a day. Okay. But not all of them are 50-50 release. Metadate CD has more of a biphasic coated bead, and it only releases about 30% of the medicine up front with a longer release later in the day. So if you have a Metadate CD product at 10 milligrams, about 3 milligrams will get released immediately. The 7 kind of continues to release throughout the day. Concerta, which is a very specialized mechanism. It's the pump, it's an Oris pump. So it uses the osmotic gradient of the gut to pump the medicine out of the pill. And its release pattern is also quite different. It only releases about 22% of the medicine from the front and 78% throughout the day. So in a Concerta dose of 18 milligrams, only 4 milligrams gets released from the front, 14 gets released throughout the day. And when you have a non-50-50 release, this really matters. I'll have parents that come in and tell me, I give my kid Concerta. The first 2 or 3 hours of the morning is hell. I can't tell it's working. And then it starts kicking in around 10 o'clock and the afternoon goes so much better. If that's the report, that's because of the way it's released. They're getting a whole lot more medicine later in the day. And sometimes if that morning is really problematic, I've had to petition like Rational Drug Therapy to ask for a short acting to go with the morning Concerta to make it work faster because mornings are really problematic. So understanding the timing and how much dose they're getting at different points can really help. Vyvanse is also an interesting release pattern where it's a prodrug. The reason it's a prodrug is so that you cannot crush it and snort it. So it's designed to prevent IV diversion of the stimulant. It has to be absorbed and go through first pass metabolism in the liver. But as a result of that, it takes longer to kick in for some people, but has a very nice long half-life. And many people think it's one of the longest acting ones on the market before this Medias has been released. You can continue to see the creative pharmaceutical engineering of these medicines. A newer one is Journey. I'm having a lot of parents ask about that. Morning ADHD symptoms are notoriously difficult when you're using stimulants because kids wake up with no medicine in their system, and morning routines can be incredibly difficult getting kids out of the house for school. And so Journey is a coated tablet that you actually take at night. The coating dissolves and the medicine starts releasing when before the kid wakes up. So the idea is that's kicked in and started working in the morning. I will admit I have not used Journey because I can't get anyone to pay for it. It's very expensive, and I've not had any kids with it on their insurance panels, and so I have struggled to get that one covered. But some of the folks that have paid for it out of pocket or have utilized sort of a partial payment have reported a fair amount of success with it. And then, as I said, you have the newest agent that's out there is the Medias, and it's designed like giving a long acting in the morning, covering all day, and then a short acting for sort of your homework dose. And it's designed to kind of have 3 release patterns to do that. Any questions before you talk about stimulant side effects? Any questions about sort of those release patterns from stimulants? Okay. So stimulant side effects can also be incredibly important to know about the timing. A side effect that occurs when the medicine kicks in may be handled very differently than a side effect that occurs when the medicine wears off. And so it's important to kind of understand when the side effect is occurring. Appetite suppression is clearly a side effect of these medicines, or people get upset stomach. This tends to be one that occurs from the result of the dose being often at the dose that it is treating the child, that they're not hungry. And often it's they're not eating at lunchtime when the medicine might be most prominent. And the result of that appetite suppression, if not managed well, can lead to weight loss. The younger the child is, especially little kids, that weight loss can be significant and has to be monitored closely. But lots of times it can be managed. So I really encourage people to eat a really good breakfast. Often when the medicine wears off in the evenings, they need to be able to have a snack, even a bedtime snack, to prevent the weight loss. Doesn't come from the medicine itself, it comes from not consuming enough calories. So sometimes parents have to work around the doses. If the weight loss is severe from a long-acting, this might be a reason why you switch someone back to a short-acting form of the medication. For kids that really struggle with eating at lunch or weight gain, I might change them from a long-acting to a short-acting. So the medicine wears off, their appetite recovers, so they can eat lunch. The other reason I might use to manage it is I might prescribe like Pediasure or Carnation Good Start Shake to have, so they get something in their bellies with sort of a deep calorie dense sort of food. Or this might be a reason we suggest drug holidays in the summer and the weekends to try to catch up with things. Insomnia can be reported. This one is kind of variable. I will say that insomnia is a huge report of ADHD in general, even untreated ADHD. I have lots of kids that are so hyper they can't settle down to bed, and parents are losing their minds kind of from that. Sorry about that. If you take the medicine too close to bedtime, some kids report poor sleep. But some kids who are really hyper sometimes report, I sleep better when I take the medicine before night. So again, it can be pretty variable, but there are some studies that for some kids it does seem to impact sleep architecture a little bit. Sometimes if it's that hyperactivity at bedtime, that's the driving force in the insomnia, we might choose a different non-stimulant medicine to treat that at night, and we'll talk more about that later. Headaches can certainly be a side effect. Usually most of the time they occur with dose changes and normalize, but headaches or symptoms that last beyond 5 days might be medication induced and will need looked at. Tics are actually a pretty controversial subject. Many of these medicines had labeling to not be used in Tourette's disorder or tic disorders. The reality is that ADHD and tics are highly comorbid. Almost 10% of kids with ADHD will also develop tics, and people with Tourette's disorder may have a 35% or more rate of comorbid ADHD, so they often come together. The latest data in larger randomized controlled trials are actually showing that tics vary greatly throughout life, and that it does not seem to matter if you treat them or not. It seems like whether you use stimulants, alpha agonists, or treat the tics directly, the tics always get better in the vast majority of people. So the current guideline is, unless the tics are severely problematic, the child usually complains of pain or getting picked on or bullied, you usually treat the ADHD and watch the tics, because the tics will likely get better with time and maybe more variable with stress. Again, everyone's a little bit different. I certainly have had kids that have had bad tics that clearly seem linked to the stimulants, but the vast majority will get better on their own. And so you really need to provide a lot of education and follow, because for most of the kids, the lack of attention, focus, and untreated ADHD may be far more problematic than the tic, and that's a conversation to have with the family. All of these medicines can trigger some moodiness. About 10% of kids will report some irritability or anger or moodiness from the stimulant. This seems to be more prevalent with the amphetamine product because of those direct releases. In a comparison study, the methylphenidate did not report as higher rates of irritability. So sometimes if the irritability and moodiness is significant in one product, I will switch to the other version of the product to see if it goes away, and sometimes it certainly does. If it doesn't go away or occur with both products, I usually pick a non-stimulant. There was a lot of misleading literature at one point that stimulants can worsen panic and anxiety. That has also turned out not to be so true. A large meta-analysis also came out this past year looking at, I think, like 30,000 kids that actually showed that inattentive symptoms of ADHD are significantly anxiety producing. The phenomenon of missing things, being worried that you're missing things and not attending can drive anxiety rates sky high. And what they found in most kids is if you really knew there was ADHD, that using a stimulant to treat it actually improved anxiety. These were kids that did not have additional comorbid anxiety, but seemed to have anxiety secondary to their inattention, which is something we did not used to talk about. We used to think about anxiety as more of a separate problem, but they are quite linked. We monitor vital signs in kids. It's recommended that you do that, monitor that every 3 months, looking for height, weight changes, impact on blood pressure and pulse. The vast majority of kids, this is not clinically significant, and they recover when you stop the stimulant. The height and weight effects are averaged at about, the height effects averaged about 2 centimeters, which is not that significant. It's about this. Of course, if you want to be an NBA basketball player, that 2 centimeters might really bother you. But for a lot of people, that's not significant. But families read about that and think their kid's gonna suffer from like dwarfism, and it really requires a lot of education about that. The weight also can be readily impacted, but can also recover when the medicine is stopped. The blood pressure and pulse can also increase anywhere from 5 to 10 points. Some studies suggest it's smaller. Again, that's why we monitor it. But for the vast majority of kids, it does not seem to cause clinical impairment. But if you have a child with another comorbidity like hypertension, kidney disease, that difference might be quite problematic. Affective dulling is a result of too much medication. This is when parents complain about their kids looking like zombies. It is completely a dose-related effect. Too much stimulant makes someone look checked out, glazed over. That is fixed by simply lowering the dose. And is almost exclusively dose-related. The risk of diversion and dependence always has to be thought about. Again, for most kids, using and treating ADHD before puberty actually decreases their risk of substance use development. After puberty, it does not feel that it increases the risk of substance use, but you lose its protective effects. The biggest problem with kids is that if they don't lock it up or they're handling it, that they give it to their friend or their parents divert it. And one of the most common ways that kids misuse their stimulants is a friend asks them for it because they think it'll help them study and they give it to them. So all my kids get kind of a lecture about not handing out the medicine and that it's for them and them only. Because if you don't have ADHD, the effects that you might have from that medicine can be quite different. And this is very rare, but if someone has risk for psychotic disorders or mania, stimulants in theory can trigger that. This is also another resource for parents about stimulants. This again is a pretty controversial thing, but in 2004, Canada pulled Adderall from their market related to some deaths related, they thought, to this medication. Many of those kids ended up having other cardiovascular risks or benefits that may have been more the cause than the medication, but this also is a terrifying thing for parents to read about, and this medication guide explains that very well. I always ask for cardiac clearance from the cardiologist or the pediatrician in any child with a heart condition or complaints about chest pain or exercise intolerance. And the best screening right now is to ask about an early history of sudden death in the family. So you catch your hypertrophic cardiomyopathic syndromes. Interesting though, several of the kids with genetic abnormalities in the heart, I always forget the exact names, but some of the kids born with 3 heart chambers, the hypoplastic left heart syndromes, they actually have higher rates of ADHD, interestingly enough. And after correction, most of the time the cardiologists tell me that the stress test that the stimulant's going to give that kid's heart is nothing like the kid running around their ICU post-surgery, not recovering, and usually encourage me to medicate them. They've never told me no, but I always like to make sure, certainly if they have unstable cardiac conditions, I would hold off, but most kids, if it's been corrected and monitored, can be closely managed. So how do you pick a medicine? Again, for school-age children, we usually start with the long-acting, work the dose up slowly, pick the lowest, work it up every 1 to 2 weeks for tolerability and efficacy. You only need about 1 to 2 weeks to see the change in the medicines. Your insurance might dictate that it takes longer. I try when I'm doing a titration to only write maybe 2 weeks worth of medicine so I don't get stuck with the pharmacy not wanting to dispense or we have extra pills. In little kids, they really want people to be incredibly cautious about making those diagnoses. Those are the kids I often see. But certainly ADHD can exist in those kids, and we usually choose short acting for little kids because of the height and weight effects. Asking what family member did well on what medicine can always be helpful if there's family history. And sometimes the most important question is, what will the insurance cover? And knowing what their insurance panel is. If you pick some of the new fancy medications, they're $700 or $800 a month. They won't be covered. You want the medicine to be affordable. And every insurance plan has a preferred methylphenidate product and a preferred amphetamine product on it that you might have to work around. The other thing that's helpful is, are there other symptoms I'm targeting? Beyond ADHD, is there anxiety, depression, PTSD, and exposure? And that may lead to other drug choices. I'm going to go really fast. I'm talking slow and only have 10 minutes left, so I'm going to fly through the last part of this. Alpha agonists, alpha-2 agonists are our blood pressure medicines that we use for ADHD. The long-acting form of clonidine is Cat-Bay. Guanfacine is long-acting form is called Intuniv, and the long-acting forms both have ADHD indications. We use these for ADHD and impulsivity, but they actually, because of some of the suppression they have in the periphery on adrenergic systems, may also help with hypervigilance, nightmares, and impulsive aggression. And they also are used off-label for tic disorders. So they also are approved to be used in combination with stimulants. So if you use these medicines for hyperactivity impulse control, you may need less stimulant dose, especially in kids that are sensitive to the stimulants or having like weight issues. The combination of stimulants and alpha agonists might be most appropriate for side effect management in some kids. I'm not going to go through this, but these medicines theoretically work by modulating the prefrontal cortex to impact things, but they also have peripheral effects in the periphery as well, where it can lower the adrenergic outflow tracts and essentially decrease firing of the vagal nerve. And so the long and short version of those is that the attention piece of these medicines does not seem to be as helpful as the hyperactivity and impulse control piece. So if you really have a kid with clear inattentive symptoms, stimulant or Strattera is probably much more helpful than an alpha agonist. Its efficacy and attention does not seem to be as good, even though in theory it does still modulate dopamine a little bit. Clinically, I see lots of children that come in just on alpha agonists, and they're not hyper and they can sit still, but they still can't read and they still can't focus. I have to add the stimulant for that symptom. The big side effects with alpha agonists are sedation and blood pressure, and we monitor that as well. It can also make kids sleep in class and cause some irritability, so you want to also be mindful of the dose. Strattera works like an antidepressant by increasing norepinephrine, but again, it works prefrontally, and that norepinephrine effect also seems to help regulate the cortex. Strattera does seem to have better indication for attention and focus. And in some studies, they've been found to be equivalent to stimulants. There's some studies that suggest it may be lower. As a result, probably stimulants still have the highest efficacy rate, but there's some unique things about Strattera that may make it better tolerated. The nice part about Strattera is it covers those symptoms 24/7 when it works. So people do not have to deal with the on-off effects of stimulants and may get nice, smooth coverage throughout the day, which is really nice for people to only have to take one pill and get that amount of coverage. Things to be aware of is they don't work fast. You have to build the dose up. It takes about 4 to 6 weeks, much like an antidepressant, to see the full benefit. And this is the only medication I prescribe that is truly weight-based. So you want to be mindful of starting at this dose, the 0.4 to 0.5 mg per kg. But to get a true effect, you have to work the dose up to kids to about 1.2 or 1.4. And some studies in well-tolerated folks, it's even gone up to 1.8 off-label for benefit. And again, probably the biggest thing I see with Strattera is that people don't get the dose up high enough for it to work. The other complication, though, with Strattera is it's a 2D6 medication through the CYP system, and about 10% of people do not metabolize it well. And so Strattera has some risk of activation agitation if you are a poor metabolizer of 2D6, and some kids will get very moody and irritable because they didn't metabolize it well. Strattera is not a Schedule II medicine. You cannot really abuse Strattera very well, and it sort of gets the benefit of if you have a child with an active substance use disorder, meaning they're using their stimulant to deal, or you think that they're going to divert their stimulant, or there's an active substance user in the house that you think may be misusing it, Strattera does not have those warnings and can be your first choice or consideration and still treat those symptoms. These medicines, because they work like antidepressants, do have the same black box warning as antidepressants to cause suicidality in some people. The rate is about 2%. You can have a lot of GI side effects from these medications, and you can dose it twice a day if kids can't tolerate it on their stomach. It can be given once a day, but in kids that complain about it upsetting their stomachs, it usually works to break it into twice a day. You can get some behavioral side effects. Again, I see that more in people I think that have more problems metabolizing it. And there is a warning about a few cases were reported with liver toxicity, but it was so rare. There's actually not blood monitoring that's recommended with this medication, but it's certainly something to be aware of if people complain about abdominal pain or it's significant. I have not personally seen this, but it certainly is reported in the literature. This has less effect on blood pressure and pulse, and so some people prefer to use it to stimulants if they're worried about that. But Strattera actually has some risk of increasing QTC. Again, I think it may be cardiology dependent, but I've had many cardiologists tell me they actually prefer the stimulant to the Strattera, especially in kids that have had risk for arrhythmia because of that slight increase. And Strattera was never thought to worsen or contribute to worsening tics, but it does not treat the tics. Clonidine and guanfacine, the alpha-2 agonists, actually have the potential to reduce tics, and this does not. And then these are the weird things that have some evidence for ADHD. You probably only see a child analysis and psychiatrists use them, but there are some case reports of bupropion, tricyclic antidepressants, Provigil, modafinil that's used for narcolepsy, and amantadine, which is the flu-like medication for Parkinsonism. They all have some mild dopaminergic action and some potential to help with ADHD symptoms, and some case reports that support their use. I tend to use these after multiple failures of other things, or actually more commonly, sometimes in kids with neurodevelopmental disorders and autism that don't seem to tolerate the traditional ADHD medicines well. I'll often think about these choices. The last thing I'm going to show you, and this will be in the email, so I have to find it. Whoop. Whoop. I have this big, giant, beautiful chart I wanted to share with you, but I need to find it here.
Dr. Swager, I have it on my end as well, if you'd want me to share.
Yeah,
I
why
do.
don't you switch out? That's the last part. I'll let you share yours. Do I need to unshare mine first?
Yes, please. Thank you.
This is a chart that she will email you. I use this chart every day. It has the colors of the pills on it and all the available doses. So you will see all the strengths in each of it. One page is all your dexamphetamine or your amphetamine products. One page is all your methylphenidate products. And the beauty of this is it tells you if you can give it liquid. It tells you if it's a chewable. If the patient doesn't know what dose they're using, they can point to the chart and you can figure out what strength they're using. The nice part is also with the databases now, you can actually look it up if you go into the drug registry, since these are scheduled too. If they don't know their dose, you can actually find it in the drug registry as well. But it's just a really helpful little chart, and it has the non-stimulants on the amphetamine page as well at the bottom. So sorry, we're getting very close to time. I wanted to leave you on more time for questions, but she will email that chart to you. Does anybody have any ADHD med questions?
Thank you so much, Dr. Swagger. That was all really awesome. And like you said, I will be attaching the PowerPoint and that chart in the recap email. So any questions for Dr. Swagger? Or comments? Perhaps you've seen patients with similar situations that you'd like to share with the group? Well, if there are any questions after the fact, just feel free to email me as always, and I'll make sure to send them to Dr. Swagger to have them answered. So I do want to just say a few housekeeping announcements, and then we'll have a brief poll at the end of the session, about 8 questions like last time. If you all could take a quick moment to fill that out, we would really appreciate it. So our next session will be on October 21st from 12:30 to 1:30 p.m. So keep an eye out for that reminder with the upcoming speaker and topic and everything like that. So with that, Dr. Swagger, I wanted to give you a big thank you for that awesome didactic. It was super interesting, lots of great information in there. So I will be attaching all of that in the recap email as well. So I will launch the poll, and anytime you guys are finished with the poll, just feel free to log off, and we'll see you guys next time. Thank you.
Thank you.